level, and you will have a chance to ask questions at the end. You can also feel free to send us via the chat questions during the presentation so that we can actually ask that to Professor Green. Before we get started, I'm just going to give, for those of you that are not familiar with Telfed, a little bit of information about the organization. Just take a couple of minutes. So for those of you who don't know, Telfed is the South African Zionist Fed here in Israel and deals primarily with three things. We deal with Klita. Klita is a very interesting concept. There are not many countries that have this role of absorption in actually helping to absorb people who immigrate to Israel, who make aliyah to Israel. Telfed is very involved in the Klita of Southern Africans as well as the Australian aliyah. Social welfare and assistance. People need support making aliyah to Israel and living in Israel. And a lot of this is community driven. So we have a very, very wide network of volunteers, staff and volunteers who actually make sure that that happens. Let's talk a little bit about the mission to promote the absorption and quality of life of Southern Africans and Australians in Israel, and to support their participation and contribution to Israeli society. I think there's something unique about the fact that when we come and live in Israel, it's not just to live here. We want to feel that we're part of the society. We want to feel that we can give back and that we can contribute to society. And we really want to make sure that we can help that and make sure that that happens. So a little bit about each one. In terms of Klita, there's actually been a very big uptick in aliyah from South Africa. You can see the numbers for 2021 over there. Over 440 new olim, and from Australia, 82 plus arrived in 2021. Do a lot of work with lone soldiers. It's not easy for those who decide to come and make aliyah and do their military service without a framework, without their parents or without their families. And so Telfed is very involved in helping lone soldiers and providing the support both to South African and Australian soldiers. And employment is crucial. If you make aliyah, you want to find gainful employment, support yourself, support your family. And so we're involved with helping to give out counseling, seminars, mentoring to help people be able to find work and to live and work in Israel. In terms of social welfare and assistance, we have an amazing scholarship program. You can see there over 500 scholarships are given out every year. And there are different types of programs. Some of them are pros, where in return for the scholarships, we actually have students volunteering, which is a fantastic way for them to give back, to meet, again, different people in Israel and to help those who need some assistance, financial need, as well as South Africans studying in Israel. So different programs where scholarships are given out. Times are still tough. I'm sure we were discussing this week. The cost of living has definitely increased. We're living in one of the most expensive, I would say, countries in the world today. Tel Aviv was recently voted the most expensive city in the world. I don't know if that makes us smile or makes us sad, but some people need assistance, and we're helping people with financial assistance, with food cards, with counseling, helping people to get back on their feet if they need that assistance, whether that's counseling or whether that's financial. Telfed has 105 apartments, so we do definitely help out with rentals. Priority is given to new olim who need a place to stay at subsidized rates. And it also gives you, I think, a very warm landing or soft landing when you have that kind of community around you of familiar faces or familiar language, so that when you make aliyah, you have a place to stay, and it's not just the apartment, it's the entire community around you. All of this is community driven, so we have a lot of volunteers who work, over 250 across the country. I would always suggest to you, if you're not involved and you'd like to get involved, it's a really, really rewarding thing to volunteer to the organization. You can get involved in a number of different ways. So always keep that in mind. We're always happy for more people to get involved and to volunteer. We run events. COVID has somewhat changed the nature of events lately. With the physical nature of events, but we do a lot of online events. Teddy is online. I see him here. Please, at the end, I'm going to ask him to talk a little bit about the amazing program that he runs with all of the events that are coming up. So when Professor Green has finished and we're done with the questions, Teddy, I'd love for you to come on and tell us about what we have to look forward to. A lot of different programs online. And we also have community awareness and community news that goes out, the magazine, newsletters, the Facebook page, the Instagram page, the TikTok page, for those of you who know what TikTok is. I don't, but some of you may. And it's just all of those different channels for people to stay involved and to stay up to date with what is happening with Telfit. So if you're interested in getting involved, we would definitely love to have you. I'm going to move over now to Professor Green. I'll just tell you a little bit about Professor Green before, Professor, I'll welcome you, and you can maybe introduce yourself and tell us a little bit more. I think that there is so much happening with COVID at the moment. I read through the questions, and I'll present those with COVID, with Omicron, which is called by many names, Omicron, so we'll have to get the name right. What about the fourth booster in Israel? What happens if you've had COVID? Can you get it again? Etc., etc. All those questions will be answered tonight. Professor Green was born in South Africa, earned his MB-CHB from the University of Cape Town, and MPH and PhD degrees from the School of Public Health in the University of North Carolina at Chapel Hill. He served as the head of the public health branch of the Israeli Defense Forces, and as director of the Israel Disease Control. In '96, he was promoted to full professor in the research track at Faculty of Medicine at Tel Aviv University. In 2008, he was appointed as professor and head of the School of Public Health at the University of Haifa, where he currently heads the International MPH program. He serves on a number of advisory committees in the Israeli Ministry of Health, including the Committee on the Control of Epidemics, and is chairman of the Measles, Rubella, and Polio Eradication Committees. So without further ado, I'm going to welcome Professor Green. You're welcome to share your presentation as well. Professor, and we'll hand it over to you.
Thank you very much, Jonathan. Just tell me if you're having problems hearing me, if everything's okay.
No, we can hear you.
Everything's fine with the Zoom.
Yeah.
It's really is a great pleasure to be with you all. Basically, it's a little difficult for me to hear myself being called professor in this kind of forum, because everyone here is pretty much a friend or a friend or a friend or family or whatever. So I'm like you to just call me Manfred, and that's the best way to address me. And I really like to be with old friends and new friends and whatever. I'll just say a little bit about my background, not so much my background, but what I'm doing in Israel, just to give you an idea of that what I tell you tonight is not just my own personal opinion, but it's what I've basically been exposed to serving on the National Committee on the Control of Pandemics and Epidemics. Now, this was a committee that was set up in the early 90s, I think 91, 92, and it was really established to deal with biological weapons. And it was a small committee of about 15 people, people from vaccines and infectious diseases and epidemiology. And that committee is now expanded, and it actually operates during emergencies, although we exercise during the year, so we have a couple of exercises, but essentially it only operates full time on when there's an emergency. And that's what's happening now, and it's been going on for 2 years. So we meet virtually 2 or 3 times a week, and we exchange material, and we read as much as we can. So we're in touch with each other pretty much every day. But I can also mention that that committee has expanded, and would you believe it, it's now reaching something about 80 or 90 people. So can you imagine the discussions we have with that size committee? But I guess the core of the committee are the people who make the most noise. So I guess we work out pretty well. And then, of course, we have subgroups in that committee. So what I'll do now is I'm going to go straight on to my presentation. I know that there are questions, and there are obviously things that you would like to know that I'm not going to deal with, and probably there are things that I'm going to deal with that you're not really interested in, but I'll try and cover just the basics of what I think is of interest tonight. And I give a course on COVID, by the way, at the university, of 14 lectures, each of 2 hours. So I need to actually take from that and give it to you in half an hour. I guess the Jonathan, can you just give me a time frame? What is my time frame?
I think you've got at least 40 minutes. So 30 to 40 minutes is fine with us.
And then, in addition to questions or including questions?
Well, we're going to leave 10 minutes for questions then.
Okay, so I'll try and finish. And if you see that I'm going over time, just stop me.
Absolutely.
I don't mind being stopped in the middle of a sentence. Okay, so I'm going to start. So I'm going to share screen again. And just tell me if that's okay. And you can see the screen. Is that okay?
Yes, can see it.
Okay. Okay, so obviously the title is a little provocative, and I guess you probably would want to say, well, you just need one more slide and give us the date, and that's the end of the lecture. But it's probably going to be a little bit disappointing because I can't really give you a date, and I'm just going to give you a kind of a timeline as to where we are and what are the problems we're facing. And then, of course, you can ask questions about the things that are bothering you. So I'm going to start off here. Let's just see if it's moving ahead. Okay. So the outline, I'm basically going to talk a little bit about the epidemiology and update. I'll talk about the vaccines, treatment, and then future prospects. And in between that, there'll be other aspects. As I say, you can obviously ask beyond these topics, but those are the topics that I'm specifically going to work on tonight. So just let's look at the epidemiology very briefly, and probably everybody knows this, but I'll just repeat it, that the first report of the virus was reported to the World Health Organization at the end of December, and it should be 1919. There's a mistake there. It's the 31st of December, 2019. So that's more than 2 years ago, or 2 years ago. So we actually, and then on the 29th of January, the WHO declared what is a PHEIC, which is a public health emergency of international concern, which basically tells countries to prepare themselves for a potential pandemic, but it doesn't actually declare it as a pandemic. And then on the 11th of February, the WHO declared it a pandemic, which just meant that the disease now was spreading widely globally and was causing serious disease. That's pretty much the general description of a pandemic. And if you look at the spread here on this picture, what I want you to do, I know it's a little bit of a complicated picture, but on the left side are the number of cases by region. And the regions I've highlighted because this is the way they're reporting it by the WHO region. So you can see that Europe is the top, and Israel actually is in the European region for historical reasons. And on the right, you'll see a graph. And if you follow that graph very quickly, on the x-axis, you're looking at the date. So that's pretty much from the beginning of the pandemic. And the colors you see here are the colors of the regions. And what is interesting here is you can see the spread of the virus as it spreads through different regions. So in fact, it's spreading, as you can see early on. It was first of all in China, and a little bit in Southeast Asia, and then it started to move into the Americas, and then Europe became much more infected, and then you could see that Southeast Asia had one wave and then another wave, and then so you could see here that the waves over the world were not exactly at the same time, and it changed. And what you obviously are probably interested in is why we see this big spike, and I guess it's not a difficult question for you to answer. That's the Omicron. That's what we're seeing right now. So you can see that with Omicron, it's just gone off the charts. So we're basically now seeing spread that we've never seen before. We're seeing thousands and thousands in Israel. We going now into 20,000 a day or whatever. And in the US, they've gone over 1 million a day. So it's a virus now that's spreading very rapidly. This is just a picture without the Omicron of Israel, just showing that we had these waves in Israel. And the waves are very much related to the type of virus that was actually spreading at the time. And it's also related to the interventions that took place. So you can remember the lockdowns and the different interventions that were in place, and then it would drop and then come up again, and so on and so forth. So this is a kind of picture that you see in these waves. I'm just going to make a couple of comments about excess deaths. There's been obviously a debate as to whether people are dying from COVID or they're dying with COVID, because the deaths in COVID tend to be in the elderly. Elderly is a very broad definition, so many people would disagree with it, but we talk of anyone over the 60 or over 65 as being elderly. But that's just a kind of a, so we say, epidemiological definition. But we do see much more mortality. In other words, it's a much more lethal disease at the older ages, and there are various theories why that happens, including having other comorbidity. But in fact, the measure that we use to look at the impact of the virus is what we call excess deaths. And there's a very interesting graph which you look at in South Africa. Because if you look in South Africa, the sort of the brown or purple color at the bottom are the reported deaths. So that's the graph. As you can see, these are the waves of the pandemic there and the epidemic in South Africa. Those are the reported deaths. And in green, those are the excess deaths. In other words, that's a number of deaths that occurred in excess of what have been expected at the same time period. So you can see, in fact, that the number of deaths reported in South Africa is way below the actual number of deaths. And that obviously is related to the fact that many of these deaths are not reported. They occur in the countryside. Sometimes the conditions are very difficult to make diagnosis and so on. So what we do is we compare countries in terms of excess deaths to look at the mortality. In Israel, you'll see that the excess deaths, I haven't got the graph up here, is a bit more than the reported, but it's actually quite close. And that you'll see that in many of the European countries, but in some countries, particularly where the reporting is not as good, you'll see a big gap between them. Same kind of thing, for example, in Russia. So what I'm going to talk about now is just tell you a little bit about the virus and its variants, because you're all hearing about the variants and the changes. This is the COVID virus, and you don't have to worry too much about the details, but this is what it's a schematic diagram of the coronavirus. It's called the SARS-CoV-2 virus, and it's a part of a family of coronaviruses. And they typically have these spike proteins. So those sort of brown spikes there are actual proteins that are on the outside of the virus, and in the inside of the virus, that brown coil there is actually the genetic material. And the important thing to remember here, or to note here, is that when we become infected by the virus or we get a vaccine, our bodies produce antibodies, and those antibodies are directed at those proteins there, those so-called spike proteins. There are also other proteins, but primarily they're against that spike protein. And in fact, the basis of our vaccines are almost primarily to make the body produce antibodies against the spike protein. And the aim of the antibody is to bind, as you can see in the blue there. These are actual schematic ideas of an antibody. That's an antibody, and it will bind to that spike and actually then take part in the neutralization of the virus. So in fact, you need to develop antibodies that are very specific to these spikes. And the body's immune system is probably the most amazing system in the body. It has a huge memory. And in fact, we can develop antibodies against virtually millions of different antigens, certainly hundreds of thousands, and they are very specific. So in fact, it's almost like a jigsaw puzzle or whatever it is. You develop antibodies that specifically fit these antigens. So in other words, if that antigen changes, in other words, if these are, then our antibodies may not, that we have from a previous exposure, we may not recognize. Maybe I'll just add a statement. As we know, when you've previously been exposed to a disease, a viral disease, usually you then develop antibodies, and then you recognize it the next time you're exposed. We all know it with measles and mumps and rubella and so on and so forth. And it's the same kind of process. So basically what we're developing are antibodies to neutralize that virus. So what happens though is this virus, like many viruses, but with this particular, it's what's called an RNA virus, because this is a single strand, or it actually could have a double, but it's an RNA type of material, and it has what we call a poor proofreading system. In other words, it replicates itself, but it makes mistakes. And when it makes mistakes, these proteins here change. And that's when that happens, then your antibodies may not recognize these proteins. And I'll show it to you in another picture. So what's happened, the virus changes all the time. So there've been thousands of changes in that virus, but most of them have been not very important, very small changes. But occasionally there have been very dramatic changes or relatively dramatic changes. And that's when we get what we call variants of concern. So we could get a variant, which is just a change. A variant of concern means that it's a variant now where our antibodies are unlikely to recognize, or it's going to be much more difficult to recognize that virus. And what you can see is the evolution here of the variants of this particular virus. So first of all, that was the first virus, which was basically in 2019. It didn't change much for a while. And one of the reasons why it didn't change much was that it wasn't circulating very widely, maybe thousands and thousands of people, but not enough. But the more it circulates, the more chance it's going to be to make changes. So we identified then in May 2020, that switched around because of the time. But May 2000, what was called the beta one, which was identified in South Africa. And then there was the alpha, which was identified in the United Kingdom. And by the way, the alpha, beta, gamma, delta, and omicron were given. These names were given because people started to get confused by the letters that we used. Initially, the lettering was the B1.17 and so on. It became very complicated. So there's the alpha, the beta, the gamma, which was found in Brazil, developed in Brazil, the delta, which developed in India, and now the omicron, which again, the first reports were from South Africa. So this is a change in that virus. It means that those proteins there, the spike protein, has changed. And this is a diagram here, which you can look at. You can see, if you look on the left, it's a complicated diagram, but this is actually a protein and the components of a protein. And if you look at the left there, you can see those little brown spots there are the changes in the genetic material here of the so-called residues of the protein. And you can see that delta changed from the previous alpha, beta, and gamma. And now omicron, as you can see, has made a very big change. So delta changed in about 30 or so of the so-called residues. And now omicron has mutated and has many more changes. So omicron is a very different form of that protein, which doesn't mean that we won't recognize it, but it's going to be more difficult to recognize. Look, obviously, the main thing that you would probably ask me is, what about the impact? And of course, we all know that the omicron is causing a milder disease than the delta. So that's a good news story. So it's changed, but it's actually, in this sense, causing a milder disease. So what I'm going to do now is talk a little about the vaccines and medications. So you can look and see what we do with vaccines. This is, again, a kind of a complicated picture, but don't worry about the detail. I just understand here that what I'm doing is putting basically vaccines on the one side and medications on the other side to show you what happens when we try and produce a vaccine to actually neutralize a virus and what happens when we try and produce a medication. So as I mentioned, with the vaccines, and we'll go into it, the vaccines, the aim of the vaccine is to prevent infection or to prevent severe infection. So we're going to give you some kind of, we're going to inject you with something, as we do with measles, mumps, rubella, polio, and so on. You inject with a killed version of the virus or a weakened version of the virus, and then you develop antibodies against it. And then when you meet the virus, you actually immediately neutralize that virus with your antibodies. So that's the aim there of the virus, of the vaccines. On the other hand, for medications, we actually want to interfere with the replication of the virus once it's in the body and actually stop it from replicating, basically, and stop it from causing damage. So those are the two areas here that you can look at, that you can see that this is done in order basically to deal with this particular virus or anyone. So what are the viruses that are in use? You're familiar with the names, the mRNA virus and a vaccine, which I'll come back to, the viral vectors, which are AstraZeneca, the Russian Sputnik, Johnson, and so on, and then the inactivated Chinese, Sinovac and Sinopharm, and then there are others. So there are basically dozens of vaccines that are in development, but the most common ones that are actually in use are these, and these are most of these are recognized by the World Health Organization. The ones that we are using in Israel are primarily the Pfizer vaccine, which is a so-called mRNA vaccine. It's a relatively new technology, which basically says that what you do is you inject what is called mRNA, not actual, it's not DNA and it's not your genetic, it's what actually is used in your cell to actually then produce proteins. So we actually injecting the mRNA of the protein, the spike protein, in order to make our body think that actually we've been infected by the virus and produce antibodies against that protein. So the mRNA is going to go into your cell. Your cell will then make proteins from that using that mRNA template. Your body will then produce antibodies against those proteins, and those are the same proteins that I showed you on the spikes on the virus. In other words, if you can imagine, it's producing those little spikes there in your body. You produce antibodies against it, and then when the virus actually gets into your body, you actually recognize it and neutralize it with your with your antibodies. And those are the mRNA vaccine, which have been very effective. It's actually the first time that they've been in wide use. But they have a very good safety record, and they are very effective vaccines. And then there are others, some of which were developed based on the Ebola outbreak. The AstraZeneca is very much based on the one that was used in the Ebola outbreak. It's also a good vaccine, not as effective as Pfizer and Moderna, but it's still pretty good. And then the Chinese vaccines are very older technology, although they do have a vaccine, I think, with a newer technology, but they're using the older inactivated vaccines, very much like the hepatitis A vaccine or the inactivated polio vaccine that we use. And then there are other types of technologies. So the question that I guess you're asking is, which vaccine should we use? How many doses? What is the efficacy of the third dose? What is the need for the fourth dose? Should we be using newer vaccines? Should we mix vaccines? Should we change the dose size? So there are a lot of questions. All these questions come up in the committees that I sit on those committees, and we actually evaluate the data on all these issues and of course many others. But this is something that is continually being evaluated in the national committees, obviously not just here, but all over. And we're in touch with, clearly, with similar committees or bigger committees in the USA or in the UK or in Europe or wherever. So the vaccine, the mRNA vaccine, and I'll focus on that because that's what's being used in Israel, the Pfizer mRNA vaccine, although some may have got Moderna, pretty much the same technology. So the initial series of the vaccine, the dose, was based on 2 doses. And this was based on clinical trials. The evidence was only for about 5 to 6 months. Clinical trial meaning that you took 30,000 people, 15,000 volunteers, by the way, 30,000 volunteers, 15,000 got the vaccine, 15,000 got something else injected into them, something that was not the vaccine. And then the infection in each group was followed up for 5 to 6 months. And in that way, you could determine how effective the vaccine was in preventing or reducing infection from this virus. And the mRNA vaccines were found to be more than 90% effective in preventing infection and certainly preventing severe infection and severe disease. But we did notice after 6 months or 5 to 6 months that there was evidence of what we call waning immunity and breakthrough infections, meaning that we saw that the antibodies that people had developed from the vaccines were declining, and that there were people who were getting sick, even though they'd been vaccinated with 2 doses. So at that time, here and elsewhere, we started to reevaluate this 2-dose schedule. And as we've done, as you know, there are other vaccines, again, like diphtheria, DTP, diphtheria and pertussis, or polio, or hepatitis A or hepatitis B, where we give 3 or 4 doses. So it's not unusual to give several doses of a vaccine to improve the immune response. And then we came to the conclusion that most of the COVID-19 vaccines, and again, I'm very much referring to the mRNA one because you may argue that there are a couple that are not in this framework, should be given as a basic 3-dose schedule. In other words, this 3rd dose is not a booster dose. It's not just to boost immunity. It's actually part of the 3-dose schedule. And recognizing that this was not tested in the early clinical trials, partly because there was a lack of time. So basically there are 2 priming doses followed by a 3rd dose. And as I say, it's similar to other vaccines like polio, pertussis, and hepatitis B. So what are the impact of the vaccine on the new variants? Because think about it, we are now using a vaccine which is based on one of the first variants. In other words, because it was developed quite a long time ago, a year ago or more. So it actually doesn't contain the new viruses. So what was done was, this is an interesting, is to look at the impact on the vaccine on the Alpha, Delta, and Omicron variants. And in this picture, which also looks like a complicated picture, but this is a very, very recently published paper where they did a very good study. And what they basically did was they were really taking serum from people who had, blood from people who had received 1 dose, 2 doses, and 3 doses, and they tested in the laboratory, they tested the reaction of the blood with the different viruses. So at the top was the wild type, which was the original virus. In other words, the one that's actually in the vaccine, the Delta and the Omicron. And what you may not be able to see easily, but what you can see here is that if you have the wild type is at the top here, and the Delta here, and so if you see at the 2-dose schedule here, this is the 2 on the left and the 3 dose on the right. Actually, the 2 on the left, you could see here, it doesn't look like quite, that a number of the people here have kind of disappeared. They got infected. In other words, the Omicron infected them. So those people who are no longer the black figures are now people who've been infected. And you can see here that after the 3rd dose, the Omicron actually is neutralized after the 3rd dose. So the first 2 doses neutralized the wild type, neutralized fairly well the Delta, and it hardly neutralized the Omicron. In other words, it wasn't really any good for the Omicron, which told us that, in other words, to actually have enough antibody response to neutralize the Omicron, you need at least 3 doses. So the 3-dose schedule is actually intended to also neutralize the Omicron. So then you would ask me, well, why do we need a 4th vaccine dose? And the 4th vaccine dose is really here to boost immunity again because of the decline in the antibodies. So what we've seen are declining antibodies after the 3rd dose. So we evaluated basically the people who had received 3 doses and looked at their antibodies some months later, 4, 5, 6 months after they had received 3 doses. And we noticed that there was a decline in antibodies, and there were some breakthrough infections. And you probably know of people who've received 3 doses, and 3 doses, and they still became infected, less than people who had only received 2 doses, and so on and so forth. So we had a long discussion then about the question of whether we should give a 4th dose. And ultimately, because we were so concerned about Omicron and the way it was spreading, and it was still not clear as to how bad the disease would be, how severe, we actually made a decision to recommend initially that the 4th dose should be given to people, what we call at higher risk of severe disease. Those are people over the age of 60 and people who have other health conditions that would make them susceptible to bad, severe disease, people who have immune deficiencies and so on. And we didn't see any important safety concerns. As I say, the vaccine is generally a very safe vaccine. So the controversy about the 4th dose may be, and we had these discussions, that it may be too early. It may not give a significant boost to immunity. We didn't really know to what extent it would boost immunity. And it uses valuable stocks of vaccine that could be used in countries where most have not even received 1 dose. So this was also one of the discussions we had, where we ultimately still decided on the recommendation of giving it to the high risk, but we are still discussing whether it should be expanded to more further in the community. There are early results now from studies done primarily at Sheba Medical Center, where they've tested now the response to the 4th dose. And it looks like the response is quite good. It's not the same kind of boost that the 3rd dose gave after the 2nd. So it doesn't boost it as much, but it still may give enough boost to give more protection against the Omicron. And again, we don't know what the next variant will be. So again, this is still something that's under discussion. A little bit about new vaccines, and I need to watch my time so you can tell me if I'm running over. So the new vaccines, the best new vaccine that we would like to see, but it's still away, is an intranasal vaccine. And the reason is that we would like to see vaccines that produce antibodies where the virus goes into your body. Those are the most effective in that sense, similar in a sense to the oral polio vaccine, which was once used, because it produced antibodies in the gut where the virus usually entered the body. So these are things that are being done now. So there is a lot of work, a real intensive work on developing new vaccines. Vaccine hesitancy, I'm not going to talk about it in any detail. You're familiar with it. It's an important problem. It's certainly making us creating difficulties in controlling the pandemic. People who are not being vaccinated are actually supplying the virus with an opportunity to spread widely and also to mutate. So we need to take that into account. It's very much fueled by the social media, but again, I'd certainly be happy to take questions. Just a couple of points on treatment options, because I guess some of you are saying, well, you've heard now that there are good treatments. We've had good treatments. First of all treatments must go through rigorous clinical trials. So I know people say they've heard about a good treatment that people say works and it works in the lab, let's give it to everybody. But you need actually to put treatments through safety and efficacy issues. In other words, you have to make sure that it's safe and that it works. And then those simple shortcuts. So it takes time. And safety issues are likely to be more of an issue than for vaccines, because vaccines generally don't have major safety issues. So the older ones were dexamethasone or steroids and medications. And then there were some medications interfering with the mechanisms used by the virus to replicate. I'll use a complicated term here, but don't worry, the virus uses what's called a polymerase. Polymerase is an enzyme which actually helps the virus and the body basically, to create new copies of the virus. And remdesivir, which has been used, is a polymerase inhibitor, which was developed for Ebola and actually directed at viruses or at viral polymerase. But there are two new, very effective medications, and this is very hopeful. And that is molnupiravir, which is Lagevrio, and then there's Paxlovid. And Paxlovid, so both, the first one, actually what it does basically, it inhibits polymerase. And you can just imagine, it confuses the virus when it's actually copying itself, and it actually copies itself as junk. So it doesn't copy itself correctly. And the second one is a protease inhibitor, which basically affects the construction of the new virus. So these are the two medications now that are available already in Israel. And they appear to be very effective. And generally, from what I hear from my colleagues, they have to be given pretty early in the disease. But we will be hearing more about the use of medications. So a few things about the future. And Jonathan, I'm going to ask you just to keep me in line if I'm running over time.
No, okay? You're good. You're good.
Okay. So let's go through some of the unanswered questions. Will the virus lose some of its virulence as it spreads? This is what we've seen for pandemics in the past. I mean, this is something that's not unusual. Pandemics eventually end. Although I'm not going to go into the Black Death or something, which could go on for many years, but we're not in that step. I'm talking about in recent time. The second question is, to what extent can recovered cases, both symptomatic and asymptomatic, transmit the disease? And to what extent can they get immunity from the disease? We know now that because of the variants, because of the change, people who have been sick from the one virus can actually then get sick again from the other virus. In other words, if you got from Delta and you recovered from the Delta virus and you get infected by Omicron, you can get sick, usually with a milder disease, because again, you have some memory, but it's still not enough to prevent entirely the disease. So one of the problems in dealing with it is, how are we going to deal with the disease because of these variants? It's not something that'll go away very quickly. And then to what extent can those vaccinated transmit the disease? The answer basically is that they can transmit it, because as I said, you're producing antibodies in your blood, but not where the virus actually enters the body. So the virus can get into the nose and throat and replicate, not causing disease in the vaccinated person, but it can spread to others. And the big question that we're asking ourselves is this disease going to become seasonal like flu? In other words, it's now no longer going to be all year round. It'll be a couple of months of the year and hopefully a much milder disease. So just quickly in retrospect, and I've mentioned that there's 7 coronaviruses that have infected humans. I didn't say it in the beginning, but the coronavirus comes from animals. It's an animal virus. In this case, might probably come from a bat, but coronaviruses are animal viruses that affect animals. And 7 of them have changed enough to infect humans. So there are quite a number of coronaviruses, but 7 have actually infected humans, and 4 of them cause the common cold. So we get colds just every year. Some of them are caused by other coronaviruses, not a very severe disease. One, which was the SARS-CoV-1, which caused SARS in 2003, caused a very severe disease. And probably because the disease was so severe and we actually were able to isolate the patients very quickly, that actual virus disappeared. Very unusual, but it did. One causes MERS, which is the Middle East respiratory syndrome, which is actually seen mainly in camels, but does cross over to humans. And it's pretty much been limited to Saudi Arabia and the Middle East. For some reason, it hasn't spread very widely. And then, of course, we're dealing with SARS-CoV-2, which is the COVID-19, which is the virus that we're dealing with right now. So some of the considerations we have to say is we haven't experienced coronavirus pandemics before. And the best comparison is with influenza. And the 1918 influenza pandemic lasted about 3 years. And in fact, this pandemic, in many respects, resembles the actual pandemic of 1918 with much lower mortality. But then again, they didn't have the same kind of facilities and medications there. So that's the comparison. But remember that influenza is a different virus. So it's again. But the virus then became endemic, the influenza virus of 1918, and less lethal, and it's still with us. The same, the influenza that we have today, which are what we call the H3N2 and the H1N1, are basically the great-great-grandchildren of the 1918 virus. So it's the same influenza virus, it's just mutated. So it's still with us. So in other words, we may be seeing the COVID-19 developing into a virus which will hopefully produce a milder disease, become seasonal, and remain pretty much indefinitely. So the question then, again, we go back to the title of this talk, is when will the pandemic ever end? Some of you have probably heard about herd immunity, and I'll go through this very quickly and show one formula just to indicate to you the complexity. It's a theoretical concept, and it actually means the percentage of the population who are immune in order to slow or interrupt the spread of the virus. But it depends on a lot of factors. It depends, first of all, on the fact that the virus doesn't mutate very much. And it also depends whether the population is homogeneous. In other words, it's spread evenly. And we don't have separate sort of communities where there's less immunity and more immunity and less vaccination. So herd immunity, in a sense, is a process of achieving eradication, but it just gives us a goal. It doesn't actually help us in any other sense, but it doesn't mean that it eradicates. So if there's herd immunity, that doesn't mean the virus has gone away. It just means that the risk of being infected has been substantially reduced. A couple of quick points on this, and I think I'll be close to finishing. You're all hearing about R. So R0, R0 is actually the basic characteristic of the virus. It's how easily it spreads. So an R0 for flu is about 1.3, which means if it's more than 1, which means it does spread. So each person infects 0.3 of another person. The R for the coronavirus, for COVID-19, for the earlier variants, the Delta even, it was around about 3 or 4. But Omicron is probably now, I don't know, could be 6, whatever. It's gone much higher. So that means that this is a much more infective virus. And it means basically that it's pushing the herd immunity level further and further away from us, because the higher R is, the higher percentage you have to actually have immune in order to then get to what we call herd immunity. I'm not going to go into it. I just wanted, for those of you who really like mathematics and so on, there is a formula for herd immunity, and it's basically a very similar one. It's 1 minus 1 divided by R0. And so if R0 is 3, then herd immunity is achieved if about 67% of the population are immune. But that's only in an ideal situation. And for measles, for example, we know it needs about 95% of the population need to be immune to stop the actual transmission of measles. And if you look at these graphs here on the left, that's basically the increase in the number of cases when Omicron came, and this is in Israel. And you can see what happened to R. R just started to skyrocket. You may get confused because it's R of 2, but it's what's called the effective R. It's not the, it's RE, it's not R0. Don't worry about that. All you need to do is worry about the graph, and you can see that R now has gone sky high, which just means that the herd immunity, so-called level, has gone beyond us. And I would say now we need 95% of the population to be immune, either from vaccination, preferably, or by disease, to get to what we would call herd immunity. So there are really two possibilities at the end of the pandemic. Back to normal. And normal we can probably think of as being what we had before COVID, when there was virtually nothing. And that's very unlikely. So we're probably going to get used to living at what we call a new normal, and then living with COVID as another flu-like seasonal disease. And if there's an effective vaccine, an acceptable level of morbidity and mortality, and what we call tolerable moderate restrictions during the season, I would think we would still want to suggest, if it was seasonal, maybe use masks. And you can, I would think it would be a good idea to be using masks in closed spaces in the winter months, but that's something for discussion. During a flu season, just if people are not always aware of it, about 10 to 15% of the population suffer from flu in a regular season. And there are about 700 deaths related to flu in a regular season. We've had in the COVID-19 pandemic, close to now to 10,000, which is like something about 5,000 or more deaths a year. So you can see it's way higher than the influenza. So the take-home message here is that we're probably still in the middle, or I would be more optimistic and say maybe we are getting into the later stages of the pandemic. We need to prepare for much wider spread with possible new variants. That's the possibility. So we're watching out for these new variants. It's still a major health threat, but we could be seeing the beginning of a milder endemic. The vaccines are effective, even though we may need to give multiple doses. So we shouldn't be too concerned about giving multiple doses. The new treatments look very promising, and we need the cooperation and compliance of the public. And the bottom line is we are not facing a national disaster, as some would say. That's it. That's now time for questions.
Wonderful, Manfred. Thank you so much. I've got a lot of questions that were sent in as part of the webinar. I'm going to go through them. I know some of you have also sent some questions in the chat, and you're welcome to send more questions. That's not a problem. I know that Doron asked, what is your favorite Manfred Mann song? I'm going to ignore that because I don't know if anyone remembers Manfred Mann, but let's look at some other questions. So one of the questions that comes up is the whole policy of, and Barry wrote this, about isolation. There's been a lot of confusion over the last few weeks with the Ministry of Health's regulations. You need to test, you need to isolate, you need to then be in quarantine, come out of quarantine. Should we just be going on with life as usual? So, not having all of the policies of isolation specifically.
I have to be, as I say, pretty careful as to what I say, because I may be disagreeing with some of my colleagues. But I just commented in one of our WhatsApp groups with the committee, somebody wrote yesterday or today that we've gone from being one of the most successful countries in dealing with the pandemic to one of the most confused countries. And I think there is a problem now with the whole question of isolation. Basically, the pandemic, or the epidemic in South Africa, in Israel, has now reached the stage where it's very difficult to control the spread. It's a very, as we say, it's such an infectious virus, and all of you could probably experience that you've done everything you thought you did right and you got infected. So it's very difficult. So what we're trying to do now is basically try and smooth out the numbers and make sure that the hospitals are not overwhelmed. So there are two. So one thing is really not to get, because even though it's a milder disease, if you take a milder disease, let's say it's 10% as mild as the older, the Delta, but if you have 10 times as many cases, you then still end up with about the same number of people coming into hospital with severe disease. So again, particularly those who are at high risk are the people that have to be protected. As again, this the older people and the people who have immune deficiencies and so on. So the isolation procedures are really to try and protect those people. We know, though, that children can children get sick, they often get a very mild or frequently get a very mild illness. There are some signs. We still don't know to what extent the Omicron will cause the what we call the multi-system inflammatory disease that we see in children, because it's too early. If it doesn't, then that's a good sign. Then it doesn't mean that it's not so bad. But I agree with you that the instructions now for isolation are confusing. And the only thing I can say to you is that you have to be patient, a little bit patient with us, because you understand what we're dealing with when we have to try and make these decisions. So I'm not saying that we're making the right decisions, but we're trying to, shall we say. So this is basically the process at this time.
I think you also mentioned that this is not something we've dealt with before. So there are a number of factors which are unknown, and as this virus progresses, we learn. Another question is the difference between natural immunity and the immunity from the vaccination. And maybe it's related to the first question. If you're going to get exposed to Omicron, so perhaps get exposed, build your natural immunity, and would that be more effective than the vaccination or the boosters?
Right, there are a couple of answers. One is, again, people must remember that this is not just another virus. It's a virus with its own characteristics. So it's not measles, where you get measles, you get good antibody response from having the disease, and then you're protected in the future, or smallpox or mumps and so on. So as you remember, people get colds every year or frequently, even though they've been exposed to coronaviruses. So the coronavirus is a little different, and the immune response is a bit different. So there are two problems there. The one is the sort of the strength of the immune response to during the disease and how long it'll last. The other is the variant. And I can talk about people now in my own family who had Delta. In other words, they were sick with Delta and now sick with Omicron. And weren't vaccinated because they were little kids. So it's not an easy. What we are thinking of recommending more widely is that people who have been ill with COVID still should be vaccinated. And the reason being, again, is that it'll boost your antibody levels. And it does look like from the data that we have that people who are vaccinated, as well as, in other words, people who have been ill and also got vaccinated subsequently, have better protection against subsequent illness. I don't want to say that people who get ill are not protected. They are partly protected. So I'm just saying that we still have this balance here that we need to deal with. I wouldn't suggest to people that they deliberately get infected. It's best to get infected, first of all, if you've been vaccinated, okay. But if you've had, so you maybe after you've had 3 or 4 doses, I'd say, okay, that may be the time, but we wait and see.
So there were a lot of questions about the fourth vaccination, the fourth booster, which you did relate to some of that. Questions about what is the logic for over 60s and medical staff who are at a higher risk. Is there evidence from the Misrata Briut, in terms of their guidelines that it's effective? I guess it's still early days in terms of the fourth booster.
So I can give you just from early data. First of all, we're targeting initially people who are at higher risk of severe disease. And it goes along with this that, if you had 3 doses and you get sick and you're 25 years old and you're healthy and so on, then the chances are you'll have a mild disease and there's no problem. So we're really trying to protect those. So talking specifically about the over 60 or over 50, it's an arbitrary cutoff, but let's assume we chose 60. So the idea there is to boost antibody levels. So we now have data, as I said, from studies that have been done in Israel, that the 4th dose boosts antibody levels. A bit difficult to translate it into numbers, but it's about 6 times. So it boosts your antibody level about 6 times. Just to give us a comparison, the booster from the 3rd dose may be boosted at 20 times or 25 times. So it doesn't boost it like the 3rd dose, but it does give a boost. So we thought that because Omicron was so wide and we still are not sure what the impact is going to be on health, and we do have people in hospital in intensive care from Omicron, so we still would want to do it. So we did that. For the medical staff, interesting enough, it's not to prevent severe disease in them. It's actually to prevent absenteeism. One of the biggest problems we have at the moment is having medical staff who are off duty. And I think if you talk to people, you'll hear about it. About 10% of the medical staff at any one time now are absent either from, and that they were already under huge pressure. So this is a major issue. So this was the reason we decided to give it a medical staff.
Okay, the questions about the long-term COVID effects. We knew from Delta that there is not just the initial disease, but there's also follow-on. Is that something that we know about in Omicron, or is it too early to know what the long-term effects will be?
Right. The short answer is it's too early. There are studies now in place that are looking at that, but it's still too early to tell. We're hoping, because it's a milder disease, that we won't have that kind of effect. We're still trying to understand the long COVID, even in the, with Delta and others, and some of it, I'm not suggesting that that's the reason, but there is one study that indicates that people who think they were infected but actually were not infected, some of them still suffered from long COVID. So you can see it's a problematic area, but I'm sure it's real though. I'm not saying it's not real.
Okay, and a question, what is the gap between resolved infection from Omicron and the booster, the fourth? In other words, I'm assuming if you had Omicron, how long should you be waiting? And do you need to get the fourth booster?
Yeah, again, I think that will be a recommendation that we'll produce at some stage, but we would certainly wait something like 3 months. Interestingly enough, it's often better to wait longer to get your next booster dose. And there is some argument even initially, because the clinical trials was a 1 month gap between the first and second. In retrospect, maybe it would have been better to have a longer gap there. So, from the vaccine point of view, sometimes it's better to have a longer interval. So I would say certainly wait at least 3 months.
Okay, in terms of the current vaccination, the current technology that you were referring to, Pfizer, do you think that is going to be the, let's call it, vaccination of choice for the foreseeable future? Do you think there is going to be a different technology coming up where we'll have a yearly, like we have a yearly flu shot, we'll get a yearly COVID shot? So, or should we expect that every 5 to 6 months we'll be getting a booster for the foreseeable future?
So there are a couple of answers. First of all, because we're in a pandemic situation, the Pfizer, Moderna, or even AstraZeneca, those vaccines were the best we had at the time. So, and they were developed rapidly, and we didn't have the luxury basically of looking around and finding something else. There is a problem with all of them, and that's a problem related to the vaccine and the virus. And as you see, that it doesn't give long-term immunity. So in other words, after 5 or 6 months, we see this decline in antibody levels. So what is ongoing now are new studies, further studies. There's still a huge amount of investment into new vaccines. New vaccines are very difficult to produce, so we don't have many new vaccines, generally speaking. They take a long time to develop, but now, because so much money is being put in, there is a hope that we will have better. But there are ideas now to mix vaccines and so on. Maybe, there may be a possibility that giving a Pfizer vaccine together with some other, Pfizer and Moderna are often mixed because they're the same technology, but we may want to give I'm just throwing it out. I'm not suggesting it, but I'm saying it's possible that we might even use the Sinovac of the Chinese vaccine as a booster after you've had the Pfizer. There's no problem basically in giving different vaccines. If you receive one type, there's no problem getting another type.
Okay, now Leslie sent the question, the antigen testing at home, the home kits, which has also caused a lot of questions. How accurate are they? Should we be taking them? Do they really pick up the I know the Ministry of Health guidelines came out with perhaps updated information on how to do the test, both in the throat and the nose, etc. So are these tests reliable? Are they accurate? Should we still be doing them to do an early diagnosis of Omicron?
Right. I think what we're doing is we're basically distinguishing between a screening test and a diagnostic test. And these are screening tests, so they're not for diagnosis. They're not going to be used for treatment in any event. So screening tests we are familiar with are sometimes fairly crude, and they don't give you so they're good at, so we say at a population level, but not so much at the individual level. So I can talk as an epidemiologist and say, I'm happy if 80% of the time it's right. You may argue for the individual that's not okay, but in fact, it's okay for me. It's just a way of limiting the spread. So I think people should see it as that way. I would say, do two things. Use common sense. If you feel unwell, stay at home, or if your kid's not well, stay at home. Interestingly enough, we've even had people coming and saying the antigen test was negative, but the kid wasn't feeling well, so we sent him to school. so that shouldn't happen. I would much rather hear that the kid didn't feel well, the test was negative, but you didn't send him to school or her to school. So I would say that we really should be thinking in terms of using a lot of common sense. And again, avoiding too many crowds. Unfortunately, we're still in that situation. So, and masks, I'm still a believer in masks. So I know there's a question about masks being raised. I still think it's a useful thing. By the way, I'm currently in Denmark because my wife is here, and I use, and the masks are very good outside, by the way, in the cold weather. So when you go out, put your mask on. It protects you from the cold.
I have to agree. This week has been so cold. I just wear my mask all the time.
Exactly.
It's been. You did answer questions about the likelihood of mutations. Is it likely that we're going to see more mutations? I think the answer, or more variants. I think that's the nature of this virus. And the question is, are they going to be? Will these variants be as mutated as Omicron? And I suppose the option or the possibility is yes.
Right. Well, the bottom line there is that the more we allow the virus to circulate, and this is another reason why we try. Some people will say, well, let's just let it go and everybody get infected and we get over it. But that's exactly the time when you get these mutations. So, that's a gamble in addition to some bad illness. So basically, let me just give you an example with polio, for example. Another one. With polio, we pretty much got rid of polio in most places, but in places where there's a low coverage of vaccine against polio, we then start to see mutations of basically of the vaccine virus emerging. And where there's high coverage, we don't see it. So high coverage by vaccine is the answer, basically, even though people will argue maybe there's some other answer, but I can't really give you anything better than that, even though my work has been primarily in vaccines, so I guess I'm biased, but I think it's still the best tool.
Okay, I'm going to look. I know people are sending in more questions, and I think what we'll try and do, if that's okay with you, Manfred, is maybe send some of those questions to you that we didn't answer, and then we'll make those available. Steve is asking about supplements. I think that's always been an ongoing recommendation to take vitamins. What would be your advice? Vitamin D, zinc, etc., just as a regular regime to keep your immune system healthy.
Well, I need to declare at the outset that I'm fairly conservative and I'm kind of one of the traditionalists and not so much. And so I maybe have less faith in supplements that can actually boost the immune system. I haven't personally, and again, haven't seen, and I don't say it doesn't exist. I'm just talking about myself. I've seen data that really support the fact that immune supplements will make you less susceptible to any of these diseases, and you can see it with the disease. I mean, people get flu, and it doesn't really distinguish between people who are healthy and who are not healthy, or eat well or eat other diseases. But there is some evidence that, as mentioned, that vitamin D is part of the immune system, and it has been used for treatment. So I wouldn't say that that's something that shouldn't be done. I can't really recommend it, but I think that it doesn't seem, as long as you don't overdose. I mean, though people tell you can't overdose, but yeah, I guess with vitamins you can overdose. So, take moderate levels of vitamin D for prevention. And it's been used with some evidence of success in modifying the disease. So it's still not altogether clear, but so it's not out of the question.
Okay, Manfred, I would really like to thank you again for your time, for your knowledge, and for answering all the questions and providing us the information. I'd like to hope we're not going to meet you in a few months for the follow-up, but I think we probably will. So again, I'd like to thank you on behalf of Telfed for your time and for your knowledge. I know there are other questions, and I will make sure we forward those to you, and we'll make sure we send it out to everyone with the answers. I'd like to invite Teddy just to come on for a couple minutes just to explain what else we have to look forward to. And again, thank everybody who joined us this evening.
Jonathan, can I just make one quick comment on it?
Sure.
Some of the pictures that I've used in my presentation are from the internet, and there may be copyrights. So please don't distribute them, otherwise you'll get me into trouble.
Okay. Understood.
You can use all the rest, but just take out the pictures.
Understood. Not a problem. Not a problem. Okay, Teddy. Let's get Teddy to tell us a little bit about what we have to look forward to.
Hello, guys, and a very good evening to you all. Thank you all for joining. Manfred, thank you so much. It's about a year ago since we last heard from you. So really, I hope that we don't have another birthday for Corona next year in January. Be all that as it may, we do have some exciting events coming up. The first event that I would like to tell you about is Blood Drive in partnership with the Magen David Adom in Ranana. See the Telford website and you could sign up and join and donate blood. We have a number of Tiulim coming up. Let's hope that we can do them because of Omicron and any Crohn and who knows. The first one is an amazing tour of Kfar Saba, the archaeological sites of Kfar Saba, the historical sites of Kfar Saba, and the establishment of a Jewish state in the Sharon area of Kfar Saba. So that's going to be one of our upcoming events. Thank you all for joining. If you would like to volunteer, I would like to also introduce Aviva Tal-Or, who's on the event with us this evening. She is the Telfed coordinator for volunteerism and for community events. Aviva will put up her web address and email address, and if anybody would like to volunteer, please feel free to do so. A good evening to you all, and thanks again for joining.
Thanks, Teddy. And thanks everyone for joining.
Thank you.
Have a good evening. Stay safe, stay healthy.
There you go. Aviva's put up her email address, and if anybody would like to ask any questions, or in fact get Manfred to answer on some questions that he wasn't able to, please feel free to email Aviva.
Okay.
Excellent.
Thank you so much. Thank you,
you,
Professor. Thank you, everyone.
Thanks, everyone.
Thank you all.
A good night to the Telfred family.
For that.
Thank you, Manfred.
Thanks very much, John. All the best.
Thanks, Manfred.
Thank you.
Thank you all.